Hello, everyone. We will get started here momentarily once everyone has joined. All right, we still have participants joining, so we'll get going here in just a second. And I see a hand raised from Angela Machuela. Hopefully I got your last name correct. If you have a question throughout the call, and I'm going to go over this in a second, just drop it in the Q&A because everybody is on mute for this webinar. I still see some participants joining, so give it a couple more moments before we get rolling. Okay. Hello, everybody. I want to thank you all for coming. Hope you're having a great day wherever you may be. My name is Lindsay Streeper, and I'm the Senior Director of Marketing and Communication here at Magellan Federal. And I'm going to be your moderator for today's webinar on suicide prevention, strategies and resources for military families. We're very glad you've joined us today during this month of September, which is Suicide Prevention Awareness Month. Suicide is such an important topic that touches all walks of life. And at Magellan, we really strive to bring forth ideas and insights to help enrich and improve lives, especially in tough areas, such as preventing the tragic loss of lives to suicide. MFed Inform is our insight series that shares valuable health and productivity solutions to those connected to the federal government. To get to the blog with the articles, webinar replays, resources, you go to the URL you can see at the bottom left of your screen. And if you are not on Zoom and you're dialing in, that URL is mfed.info/inform. And once you get there, be sure to subscribe. That way you'll be the first to hear about new available topics and information. All resources are free and open to the public at that location. So before we get started, there are just a couple housekeeping things I want to mention so you can make the most out of your time here with us today. The first part of the webinar, we're going to share the wonderful content that our panelists have prepared. And at the end, we're going to take your questions with any remaining time that we have. This webinar is being recorded for all future on-demand viewing, and all registrants are going to receive a replay after the call. It will also be available on that MFed Inform blog for those that may not have registered. Your lines, as I mentioned, are muted throughout today's session, but you can ask questions, any of them at any time, by going to the Q&A at the bottom of your Zoom window and just go ahead and type it in there. So thank you all for joining us, and let's go ahead and get started. Before we dive into the agenda and what we're going to cover today, I wanted to provide a brief overview of who we are. Magellan Federal has team members all over the world at government installations and agencies delivering sensitive, complex wellness services. Our mission, as you can see here on the slide, is to inspire healthier, more productive communities by delivering innovative, total well-being solutions to the federal government, military personnel, government employees, and their families. We deliver services in areas such as mental health and substance abuse, family support, fitness for duty, wellness, coaching and care management, veteran benefits, and various administrative professional services too. So that's a little bit about us. You can go on to the next slide. Magellan Federal is part of Magellan Healthcare, which has additional suicide resources available to the public on this website that you see here at that URL. And I'm going to drop it in the chat as well for those of you who may be on the call. So make sure to bookmark that. There's a lot of good resources there to help you take action and just to have real awareness this month as well. Next slide, please. Today, you're going to hear from several panelists, and all are members of our Magellan Federal team. And you can see their lovely faces here. And they represent several of our key programs that do this type of work every day. So I'm going to give them a moment to introduce themselves. Go ahead, Jason, since you're first on the slide.
Hi, my name is Jason Kuttner, and I'm with ASACS, which is the Adolescent Support and Counseling Service. We provide school-based counseling services to military-dependent adolescents internationally and in the state of Hawaii.
Perfect. Welcome. Now, Scott.
Hi, my name is Scott. I'm a supervisor with the MFLAC program. Some of my background, I'm a marriage and family therapist, a licensed professional counselor, and in my government work, I was a suicide prevention program manager for the Installation Management Command in Europe.
Perfect. Now, Deanna.
Good afternoon, all. My name is Dr. Deanna Emanuel, and I am a licensed professional counselor and field consultant with the Federal Occupational Health EAP and Work-Life programs.
Wonderful. So you'll hear from our panelists throughout today, and they're going to cover these things that you see on the slide. In our time today, we'll cover the scope and prevention approaches for military families and adolescents. We'll give you some intervention tips for all individuals. We'll talk about postvention techniques to help yourself and others with grief and loss. And we'll give you some wonderful resources to help veterans, adolescents, and survivors. And finally, as I mentioned, we will take your questions at the end. So the unfortunate reality is that likely all of us on the call today have really been touched in some way by suicide. So our hope is that the information and strategies that you get today will help you better feel equipped to address this pressing issue. So with that, I'm going to turn it over to our first presenter, Jason.
Thanks, Lindsay. Yeah, you're right about that. I mean, pretty much all of us will be touched, if we haven't already, by suicide at some time in our lives. The reason we're here today is because suicide among active duty military and veterans is too high, and a broad range of approaches is being implemented to try to address the suicide epidemic. Let's go to the next slide. This slide will show, it's a very grim reality. There's more than 6,000 veteran suicide deaths every year, close to 600 active duty deaths, and 200 military family member deaths annually. The suicide rate for veterans is 57% higher than that of non-veterans. Another way of looking at that number is that it's 1.5 times higher than non-veterans. Among veterans under the age of 45, suicide is the second leading cause of death. Also very important to know that among US adults who died from suicide in 2020, firearms were way more common among veterans than among non-veterans. The reasons for such high rates of suicide among veterans include high exposure to trauma, stress and burnout, isolation and loneliness, difficulty reintegrating into civilian life, and easy access to and familiarity with firearms. Now, what this slide does not show are the data regarding active duty military deaths. And just a little bit about that. And that is that for many years, active duty suicide deaths were actually lower than the general population. But in recent years, the rates of active duty suicide deaths have been increasing and have caught up to the general population. Next slide, please. Firearms are the leading cause of death for veterans, active duty military, and also adolescents. In the case of a suicide, one of our most important prevention tools is restricting access to means. This is a regular component of safety planning with a suicidal person. A suicidal crisis is often brief. Many suicides and suicide attempts happen in a time of anger or extreme emotional upheaval, often exacerbated by alcohol or drug intoxication. That's why it is so important to do something about the firearms of a person who may be experiencing a suicide crisis. There's a continuum of options that can help with this, including trigger locks, locking gun cabinets, and being able to identify trusted friends and family who can hold the firearms until the crisis has subsided. A suicide attempt with a highly lethal means, such as firearm or fentanyl, is likely to result in death, although not always. Years ago, when I worked as an involuntary commitment investigator, I met with a young woman who survived a self-inflicted gunshot wound to her head. She regretted her attempt, and she was glad she survived it. In fact, most people who survive a suicide attempt are glad they did. Putting time and distance between a suicidal person and a lethal means of suicide may save a life. And it's a really important part of safety planning. Incidentally, I've also had multiple adolescent clients tell me that they know where their parents keep their guns and would know how to access them. So that's another really important reminder for people who keep firearms in their home to make sure that they are kept secure. Next slide, please. Thankfully, restricting access to lethal means is not our only prevention tool. Working with a therapist is, of course, an important approach, but it doesn't serve everyone, and not all military members and veterans feel ready to go that route. There have been increasing recognition that community building, which can include socializing, hiking, volunteering, getting together with common interests, basically anything to get people together in person, can be very strong protective factors. Teaching veterans and family members about suicide risk factors and basic communication strategies, such as those taught in ASSIST and Safe Talk, can be immensely helpful. Also, the VA is partnering with outreach organizations such as the Cohen Clinics, which is a national veteran serving organization. They're partnering with these types of organizations to be able to reach out to vets who are more isolated, such as rural veterans, homeless veterans, etc. Next slide, please. So for the next part of this presentation, we're going to talk about adolescence. The reason that we're doing so is because so many military-dependent adolescents also, experience many risk factors. The ASACS program, the Adolescent Support and Counseling Program, works with military-dependent adolescents overseas and in Hawaii to help with mental health issues in general, and many times we're working with potentially suicide adolescents. Incidentally, also the MFLAC program, works with the same population. Yeah, thank you. Teens today are reporting very concerning levels of hopelessness, sadness, loneliness, and suicidal ideation. The annual Youth Risky Behavior Survey, according to the annual Youth Risky Behavior Survey, the numbers are very alarming. In 2021, 57% of girls reported persistent feelings of sadness and hopelessness. 29% of boys did the same. And among LGBTQ plus youth, 69% reported these persistent feelings of sadness or hopelessness. Teen suicide rates have been rising in the past several years, and LGBTQ plus youth and youth of color have had the highest increases in suicide attempt rates. In 10 years, from 2011 to 2021, the youth suicide rate rose from 6.8 per 100,000 to 10.7 per 100,000. In 2021, an astounding 10% of high school age students attempted suicide, and 22% seriously considered it. I pause when I say it because even though I work in this field, the numbers to me are still incredibly astounding and very concerning. Among LGBTQ plus youth, 20% report attempting suicide and 45% report seriously considering it. Okay, next slide, please. We in the ASACS program have thousands of clinical sessions with adolescents every year. We also conduct prevention education to them at school. And so we learn a lot from them. We learn from them why they are struggling. And this is some of what we've learned. Anxiety and depression rates were already increasing prior to COVID. And since COVID, it keeps getting worse. Many teens report a lack of connection and community. And I call it the social media paradox. The internet was supposed to be a place where we could all belong. But research is really clearly showing that it's been a huge source of anxiety in terms of comparisons, and judging self and others. There's been a very close correlation between social media use and serious mental health issues. Teens also report concerns around social justice issues, inequity, and fear of oppression. Since the George Floyd murders and subsequent social upheaval, also with many LGBTQ plus youth, the recent backlash against gay and transgender identities in much of the US has been a source of a lot of anxiety. Bullying, blackmail, social exclusion, exploitation online, these things are real. These are not just things that you hear about in the media. We in the ASACS program hear about these things happening all the time from the teens that we work with. And then also the usual stuff, the usual stressors, academic, family, relationships with friends, and romantic relationships. And we also hear a lot about worry about the future, the ability to pay for college, to buy a house, wondering if the world will be a safe place to raise their own families. These are many of the concerns that are facing youth today. Next slide, please. In light of that, what can those of us who work with youth do? So these are tips that I think are really important for anybody who works in a school setting or works in an organization who works with youth. These are some really important strategies. One is broadcast available resources. Students should know what resources are available to them in their schools and community. That would include counselors, trusted adults, and the 988 crisis line, which Scott will talk about a little bit later. Train staff. All staff in a school setting should be trained in suicide risk factors and in how to ask, care, and escort to get their students help. All staff should also be trained annually in mandatory reporting so that they know when they're supposed to take a student crisis to the next level. Emphasizing peer-to-peer support. Peer-to-peer programs are immensely important. Teens know when another teen is not okay, and training peers in leadership programs to look out for each other can have a very important impact. Integrating mental health providers in schools is a very important component as well. ASACS is a school-based behavioral health model, which is increasingly being used by school districts around the United States. Basically means that behavioral health providers are in the school where and when they are needed. And then finally, schools need to have a suicide risk assessment protocol and a designee to conduct those suicide risk assessments. Just doing a suicide risk assessment reduces risk. When you use a strengths-based suicide risk assessment model, safety planning is conducted as part of that risk assessment, which almost always results in the reduction of risk. So that's the end of my component of the presentation. I'm going to hand the mic over now to Scott. Thank you very much. I'll be here for questions later.
Thank you, Jason. Next slide, please. So I'm a firm believer in keeping things simple and practical. The steps found within the ACE or Ask Care Escort guidance are perhaps some of the most fundamental tools that can be used by the community at large to get those struggling with suicidal thoughts to appropriate care. I say this as someone who supervised suicide prevention within the Army, and I've seen how effective ACE can be as a training tool. The steps are in theory simple and concise, and they can be shared and taught to a larger audience quite easily. As Jason mentioned, they can be used with youth as well. The ACE model is also referenced within materials for all branches of service and even the VA. And please understand that those other trainings like Assist and Safe Talk are equally valuable and important, and I encourage that we consider them all. One advantage of ACE is that we can empower those with the most access to others, for example, friends, spouses, battle buddies, or leaders, to recognize that someone might be struggling, encourage them to ask directly about intent, and to provide a map of how they can provide support. A key component is to be direct, but do so with empathy and compassion. I want to stress the importance of showing concern, establishing a connection, and taking the time to be present. Once you have that rapport and establish a connection, you can ask directly, are you thinking about killing yourself? Based on their response, you can get them to the support that they may need. When we normalize intervention, we empower action. Let me say that again. When we normalize intervention, we empower action. While this guidance is simplistic and meant more for the general population, I believe that the takeaway for mental health providers is to remember your training and take time to invest in your client. Rapport, concern, and empathy can be your ally. For those of us on the call who operate under a non-medical framework, and once we cover our limits of confidentiality, our connection to the client can create opportunities for us to intervene, facilitate a warm handoff, and hopefully save a life. Next slide, please. One potentially promising development is the recent passing of a law referred to as the Brandon Act. This legislation creates a self-initiated referral process for service members seeking a mental health evaluation and aims to reduce stigma by allowing them to seek help confidentially. The Brandon Act is named after Petty Officer Third Class Brandon Caserta, who died by suicide in 2018. The legislation was signed into law by President Biden on December 27, 2021. The Brandon Act is designed to protect service members who experience mental health emergencies and reduce the stigma around reporting. This bill will allow service members to seek mental health treatment and require a mental health evaluation as soon as a service member self-reports. It will also allow Americans serving in uniform to seek confidential help and, if necessary, do so outside of the chain of command. The measure mandates that the Department of Defense will provide annual training on how to recognize when service members may need a mental health evaluation as well. The different branches of the military have implemented policy as a result of this law, and time will tell. Hopefully, research in the coming months and years will show that this legislation has been beneficial. Next slide, please. While many of us in the field know and share information about 988, there's always more work to be done in marketing this valuable resource. According to a poll released by the National Alliance on Mental Illness, 82%, that's right, 82% of Americans are either unfamiliar or had never heard of the 988 crisis line. Specifically, it is important to make sure that our clients are aware of its existence and to ensure that our active duty population know that they have the additional option to dial 1 so that they can be directed to the Military and Veterans Crisis Line. This provides the extra advantage of connecting to call centers that specialize in helping service members. As the slide references, almost 1 million of the 5 million total contacts were linked to the Veteran Crisis Line. And in no way is 988 meant to be the only resource we can provide to others, but it is a constant, available 24 hours a day, 7 days a week, and 365 days a year. Another advantage is that the Veterans Crisis Line can be accessed by service members overseas. In Europe, for example, as an Army civilian, I led the project that created a toll-free European number and a 3-digit DSN number that connected service members stationed in 8 countries to the crisis line. Service members should always look at their local overseas installation website for more specific information on how to connect to the crisis line, and I would encourage leaders to share that information within their commands. And even though I've referenced the Lifeline, it goes without saying that a vital resource for service members in crisis is always their chaplain. Installation behavioral health providers, the emergency department at the military hospital, and their commands. Outside of a crisis situation, there are a number of non-medical, and again, I stress non-crisis support options to include the MFed program. Next slide, please. And now I'd like to invite Deonna to discuss possible postvention.
Thank you, Scott. When talking about suicide prevention, it's important to have those conversations about prevention, intervention, and postvention. We've talked about prevention and intervention components, and now we're going to focus on postvention. Postvention refers to activities that focus on supporting survivors of suicide loss, decreasing risk, and promoting healing after a suicide. In this section, we're going to be talking about helping ourselves and others with our grief and with suicide loss. Helping ourselves involves acknowledging the loss and accompanying grief, recognizing that there is no clear timeline or guidebook for the grieving process, allowing ourselves to sit with our feelings and express them appropriately, being mindful that our feelings may ebb and flow and that they can pop up at inopportune times. It's also important to find ways to remember the deceased. Next slide, please. We also want to actively care for ourselves by being sensitive to our needs, taking time as needed, practicing self-compassion, and engaging in self-care in various dimensions. Physical self-care could include getting regular sleep, eating a healthy diet, exercising consistently, decreasing alcohol and caffeine consumption. Emotional self-care involves using relaxation skills, being aware of our own vulnerabilities, setting limits for ourselves. Social self-care involves seeking support or care from others, being aware of withdrawing and isolating behaviors. And spiritual self-care could involve using religious and/or spiritual resources and communities, practicing gratitude, meditating. Next slide, please. It is important to connect with others and reach out and not to isolate. Connecting with others could involve utilizing our informal supports like family, friends, and colleagues, or formal supports like the EAP or other types of support for grief, like support groups. The two listed resources on this slide provide information for such support groups. The American Foundation for Suicide Prevention provides a list of suicide bereavement support groups throughout the US and internationally. And Friends for Survival provides support group meetings that offer peer support. Next slide. If you are looking for other ways to connect, there are various hotlines that are available and can be found on this slide. Next slide, please. In addition to some of those considerations that were just covered, when we're considering how to help others, it's also important to be present, honest, and patient. When trying to figure out what to say, instead of saying something like, I know how you feel, maybe try, I don't know what to say, or I have no idea what you're going through. I want to be here for you. Consider the type of help or support you can provide. Share about support groups and resources. Engage in advocacy efforts. Next slide, please. It's also important to note that children and adolescents grieve differently than adults. Here are some things to consider. Tell the truth. Use short and simple explanations that are developmentally appropriate. There's an article that's hyperlinked on the slide that's provided by the Dougy Center, the National Grief Center for Children and Families, that provides information on developmental responses to grief for children and teens between the ages of 2 to 18. Other things to consider include recognizing that this conversation can be revisited and that grieving can occur in cycles and it's okay to take a break. Be prepared for a variety of emotional reactions and respect differences that come up in grieving styles. Listen compassionately, answer questions, and listen without judgment. Use open-ended questions and provide time and space for a child or teen to share their feelings. Provide opportunities to say goodbye and make choices about the funeral or memorial or celebration of life. Talk about and remember the person who has died. And make sure to reach out for additional support for yourself and for the child or teen. Next slide, please. I'm going to turn it back over to Scott to go over some resources.
Thank you, Deanna. So in the following slides, we've provided a number of resources to include books and websites that are meant to help those, including children, who are impacted by a death by suicide. I'm not going to go through each item, and this list is by no means exhaustive. We're well aware of the fact that many of you might know of additional resources that we didn't list. Most important, though, is that each of us continues to learn what resources are available and continue to share that information. Please make use of these resources to help you, your family, your friends, and your clients so that we can all enhance our knowledge and work together to make a difference. And now I'd like to pass it back to Lindsay.
Thank you. This is a lot of really good information for everyone. And so we're going to move into the Q&A portion of the call. So I'll close up the screen here so you guys can see everyone. Let me change the view for you here. A lot of good questions coming in, so use that time now to think of anything you want to ask the panelists. We have several in here that we will address as well. Change it to the gallery. There we go. Okay, so Scott, did you have a couple that came in prior to the call that you want to address first?
I do. So specifically with regards to the MFLAC program, we did have the Mythbusters brief that was there, and currently we do not have handouts that replaced Suicide Mythbusters presentation. Magellan's Learning and Development team recently submitted a suicide prevention psychoeducational presentation as a proposed replacement for that Suicide Mythbusters brief. This is currently under review with the government, and I guarantee that leadership will communicate the release of this new material when it occurs. I think that's really important. Another specific question that concerned MFLACs that people submitted in advance. What specific program can MFLACs participate in regarding suicide prevention? I think the most important answer there is that MFLACs should always communicate and coordinate with their regional supervisor about any activities they're asked to do on the installation to ensure they're in scope. And we also just want to make sure that our POC has no issues with our efforts. Another question included, how much involvement should the MFLAC have in addressing suicide ideation? So where does our scope end and referrals begin? Suicide prevention is everyone's responsibility, but especially so, we're all clinicians. And if you suspect suicidal ideation, safety always comes first. Remember, we don't formally assess for suicidality, but if you suspect a risk, please ensure a warm handoff is facilitated to ensure participant safety. And I remind you to refer to our duty to warn and mandated report training, and always seek guidance from your regional supervisor. The last specific question we had regarding the MFLAC program, are there particular subtopics of suicide that MFLACs can address while staying in scope? Absolutely. MFLACs can and should brief any topics provided by the OSD learning library that are within the non-medical counseling scope of service. If you have any questions about whether something might or might not be appropriate, again, your regional supervisor is your best source of information. Lindsay, that was the end of those specific questions.
Great. Thank you all for asking those questions. When you registered, there was an opportunity, so we addressed a few of those there. I'm seeing a number of questions come in, which is wonderful. Thank you for these. Some of these we may have to get some answers and get back to you on, but there's a good one here. And I first want to mention too, I've seen several comments about links not working, or will we get this after the call? So yes, you will definitely get this presentation after the call for all registered. So even if people registered and they weren't able to attend, this will be sent out after the call where those links will be active. So just want to make sure that you guys knew that, because there are lots of good resources in here. One of the good questions that I see in here is around the Brandon Act. And again, this might be something that we need to follow up with this individual on, but Beverly Lee Campbell asks, are there critical or are there criteria or limitations for the Brandon Act when active duty service members are PRP? And I'm not familiar with that acronym, but maybe one of you guys are.
I would only say at this point, the Brandon Act, there's a lot of policy that's been created. And I think a lot of the services are getting this out and still kind of figuring out how to implement it. So, whatever status one might be referring to, I think it will be, take some time for the behavioral health programs to pick it up and to know, and commands to actually follow the guidance. And so I've seen policy in most of the services, actually all the services now, and I'm excited to what this might bring. So specifics, you'll have to wait and see.
Great. And Jason, I see you're typing an answer to this, but maybe you want to share. There was a question in here. One of the techniques suggested to assist someone in the moment, and now it just disappeared. Maybe because you stopped answering it. Do you see that question in there? Oh, there it is. Of the techniques suggested to assist someone in the moment, is there one technique of helping them that stands out as the most effective?
Yeah, so again, I'm going to bring it back to what Scott was saying about ask, care, escort. Um, Really, the first thing is that if we're concerned about somebody, and I don't know if the question is from a clinician or not, and it doesn't really matter because there the way that we want to approach this is similar no matter what our level of professional training is. The first thing is that if we're concerned about somebody in our lives, somebody we know well or we don't know well, it's okay to ask them, are you okay? And that's a really good place to start, to ask them if they're okay. A lot of times, we don't want to intrude in people's lives, whether we're close to them or not. And so we just don't really know kind of where to go. But starting with asking somebody if they're okay is a good place to start. If they're showing signs of any kind of warning signs or risk factors, things that are, giving you a red flag or just kind of giving you a funny feeling, it's totally okay if you're comfortable to ask them if they're thinking about killing themselves or thinking about suicide. The next steps, that's the ask part of ask, care, escort. The next part is the care part. That's when really we want to try to be there and listen empathetically to the person who is struggling. We don't want to shut them down. We don't want to tell them all the reasons they have to live. We don't want to try to, convince them otherwise, but just listen to them and say, wow, it sounds like your life is really hard right now, or that really sucks. I mean, just really being able to empathize is just very important. Then we're not the ordinary person, even a clinician, in some settings, we're not going to be the ones who are then going to then manage that or to fully assess them. What you can do though is the next part of ask, care, escort, which is escort. Get them to somebody who is an expert in the field of suicide assessment who can then take over from there. A good option would be to call the 988 crisis line together. If you're not sure if it's a suicidal crisis or not, it's okay. Call the 988 crisis line and talk with them together. Take them to an emergency room if you don't know what else to do. So really, that's kind of the basics in terms of in terms of what to do, how to help. We mentioned earlier Assist and Safe Talk. Assist is, I believe, a 2-day long program. And I can't remember. Safe Talk is a shorter program. I think it's a several-hour program. These are both free. They're conducted by Living Works. There are many in many different communities, especially where there are military installations. And these are really good trainings that are intended to train peers, ordinary people, people who don't have clinical background and clinical skills in terms of how to be a helper with people who are dealing with a mental health crisis.
And if I can tack on, Jason, a lot of people worry that if they ask somebody if they're thinking about killing themselves, it's going to kind of provoke them to take action. And the research going back even to 2014, Diazi et al. Doesn't back that up. Research is very clear that asking someone generally tends to help more than it hurts. I found one quote on a VA flyer, and it basically said, asking a veteran about suicide does not create suicidal thoughts any more than asking about chest pains causes a heart attack. And I think it's really important for us to remember that.
Yeah, very good point.
Yeah, that's great insight. Thanks for providing that. Here's a good one. You talked about reasons for the increase in teen suicide, such as social media and anxiety. I'd like to know if studies have been done about parenting and family dynamics and how that has played a role in the increase of suicide among children and teens.
I don't have a good answer for that. So I'm sure that there's research being done on that. And I'm sure that, we can speculate about how parenting can contribute. But my short answer is that I don't have, I don't know about that. I can say that it's very important for parents to do what they can to try to connect with their teens, to try to find that right balance between being strict and being permissive. So really kind of finding that sweet spot. You want to be able to connect with your teen, to be able to listen to your teen, to understand your teen, to know what's going on in their lives. But we also have to set limits as well. We can't just let our teens kind of run wild and don't give them any restrictions. Many parents are very, very afraid to do anything that controls a phone. You take a phone away from a teen, and oftentimes they can revert to being a toddler in terms of having a tantrum. And so being able to set appropriate limits with phones is a really important parenting skill. That can include setting screen time limits. That can include, being able to monitor what your teen is doing online. But even more importantly is hopefully being able to talk with them about what they're doing. Be interested in what they're doing on TikTok and on Instagram. Be interested, have them tell you about it. So then you can engage them in conversation about it.
I'll just add, I echo what Jason's sharing. With regards to like research, I would say, yes, it's always very ongoing. The NIMH just put out a few months ago about a study that they're supporting that's been looking at just like the increase of suicide among adolescents during COVID and kind of looking at the impact and the different factors that have been going there. So I want to say it's always an area of ongoing research too.
Good information. Thank you, guys. This question was submitted prior to the call as well. How do I help someone who refuses help? And this could be adolescents, veteran, anyone. Is there blanket information or guidance you guys would offer around that?
I think that's always a tough one. I think as clinicians, we kind of know things that we can do, but I think as a layman or a layperson, you've got a family member that's struggling. I think sometimes you just have to make sure that they get to somebody who can help them. And whether that be that you just have to, take them in to the ED or somewhere like that. It's not comfortable. It's not easy. Clinicians, we all have kind of techniques and things that we do, but if you've got a battle buddy, for example, and you're a Marine, and you're worried about them maybe harming, their buddy harming themselves, I think at that point you go to command. We all have a responsibility to do something. And just because somebody doesn't want to go, sometimes it gets a little uncomfortable. But in the end, providing that help is good. Now, if you need specific techniques, if you're a clinician, always call your supervisor if you've got a situation. I don't think there's a real broad stroke answer for this, but bottom line is don't give up and don't step away. You need to stay engaged. Can I answer one more question, Lindsay? Mm-hmm. There's a specific question about MFLACs and what suicide risk assessment we would use. Absolutely none. We don't do suicide risk assessments. Our role is to meet the client, make sure they understand and acknowledge the limits of confidentiality. And then during that session, if they say something where we're concerned for harm to self or others, for example, we call our supervisors, we follow the protocol to do a warm handoff. But please, if you're an MFLAC, new or more experienced, we do not do suicide assessments.
Thanks for clarifying that. There's a question here about the 988 number and OCONUS access. I know, Scott, you mentioned that. Is that link provided in the presentation as well for the OCONUS access, or what is your recommendation there to get that number?
So it's broad and it depends. So if you're in Asia, it might be different. If you're in different European bases, I mentioned that I was kind of involved in a program for 8 specific countries. DSN 118 on those installations in Europe, this was Army, Navy, and Air Force, was an option. It was just toll free. The issue was always it cost too much. And there's still, even if you go to ramstein.af.mil, the toll free number is listed. So my guidance to anybody on this call that's wondering, depending on where your location is, how do I give this information to the service member? Go to the website and do a little research. With VoIP and other things now, there might be different options as well. So technology has actually greatly enhanced our ability to support those overseas. But I think always kind of defer back to the local installation information so that we get the best information out there.
Are any of you all familiar with the QPR technique? And I'm not familiar with what that is, but if that is something that any of you on the call may know. That question was from Marjorie Baker. So if you want to type in the acronym.
I know that QPR refers to question, persuade, refer.
Okay.
And it's very similar in principle to ACE, so ask, care, escort. So with the question being referring to ask, persuade, is really, I think, more about being able to assure them that it's important to be able to, get additional help, to let you kind of be there to listen, and then refer is again getting them to somebody who can make sure that they can stay safe and conduct an assessment. So I think it's very similar to ask, care, escort.
Gotcha. Good clarification there. This is an MFLAC question about the ACE technique. So what you just said, Scott, about not being able to do the assessment, the risk assessment, does this mean that MFLACs cannot implement the A part of the ACE? It's the ask. How would you say that you interpret that without the risk assessment?
Well, I think we just, in the journey of our counseling, non-medical counseling, things might be provided for us. The ACE is really just, I meant it to be, for the service members and those that maybe aren't as trained as we are. There's techniques that we can use and things that we might hear that might, provoke us to kind of, intervene a little bit. I think it's really important that we just, we rely on our training, rely on our policy, and we stick to the procedures according to our DTW, duty to warn policy, and we follow those to the letter. I think that's kind of where we should land on that answer. But I think ACE is great for service members. I'm a big fan.
A lot of good questions here. And if you put one in the Q&A that we've not answered, or we may run out of time answering because we need to provide some closing statements as well. We will try and circle back with you. If you have put in your name associated with that, we will able to answer it. Otherwise, if you're anonymous, we feel free to reach out to our Ask Me Anything inbox. That's askmeanything@magellanfederal.com. But do you see any more in here, Scott, Deanna, Jason, that you want to address live on the call here? We have a couple more minutes before we do closing comments.
The only thing I would add is I think in the questions that we received before this, we received a lot of specific clinical type questions. And I think our intent for this particular brief, was just to kind of provide an overview. And, I think all of us that are licensed clinicians and we have those questions, there are a lot of excellent CEUs and trainings out there. And I would just encourage you to stay current on the research, get out in front, don't rest on your laurels. There's constantly things coming out that are going to be useful to us. And so, any of those clinical type questions, I would urge you, especially with the benefits that we have, to try to find some CEUs that might actually fit for your intent.
That's really good information. And I think we will end on that one. I want to provide a little bit of information about just where you can get this information. I know I shared that as well. We hope you got good information from our panelists today. We will send out a link to the replay. And on the slide there that you're seeing pulled back up is if you use the QR code, you can get to our MFed Informed blog. And you can sign up to receive, future information about other articles that we're putting out. We're about to actually put out a whole white paper on military suicide and prevention techniques. That should be coming out in the next week or so, and an additional article we're working on concurrently throughout the month of September. So I do encourage you to sign up there and stay connected to us there. I'm going to put a link to right now in the chat to the email inbox. You can email Ask Me Anything, which is what I just said, but you can also email MFed Inform. So if you have questions for our panelists after the call, feel free to reach out that way. You will also receive a survey after the call today about the what you received, what you want to see in future topics. I'm also putting that link in there now. So if you want to take that survey for us to give us your feedback, we are here for you to give you information on important topics such as this. But we appreciate your time and attention today. And we hope you all got something out of it, and we can all work toward a happier, healthier society. So thank you for joining, and thank you to our panelists. And we hope you will come again. Have a good day.